So basically, like, especially for Medicare, the way, and you'll see it, I think later this week, the way Medicare works is a true treatment note solely documents what was done. A treatment note does not justify medical necessity. A treatment note does not show progress. A treatment note does not do anything except, at the minimum, document what was done. Okay. A progress report required by Medicare every 10 sessions or sooner. A progress report shows progress or decline or plateaus. A progress report addresses the goals. A progress report supports medical necessity, um, and kind of just follows the plan of care. You can combine your treatment note and your progress note, or you can keep them separate. And so when you see the Medicare published example of a progress report, it's super short. If you followed the Medicare guidelines, documentation would be a breeze. And like I said, we make documentation tenfold more complicated than it really needs to be. So these are important factors. I combine my progress report with my treatment note. And so what the formula is, I can't say that I follow it, but this is what it should be, is session number 1. We do the initial evaluation. We document the treatment provided with the initial evaluation. Session number 2, we document, let's say in the eval, the plan of care, we establish 4 short-term goals, 4 long-term goals. Okay, that's pretty typical. Session number 2, first follow-up treatment, that whole treatment is based on short-term goal number 1 from the plan of care.
Sure.
Treatment number 3, I focus on short-term goal number 2. Treatment number 4, goal number 3. Treatment number 5, goal number 4. Now, 5 treatments in, I've covered all 4 short-term goals. Treatment number 6, long-term goal number 1, long-term goal number 2, long-term goal number 3, long-term goal number 4. By my 9th treatment, I have addressed all 4 short-term goals and long-term goals. My progress report is done by session number 10, right? So I don't have to do a separate progress report because I've addressed all the goals in each of my daily notes, each of my treatment notes. Now, if I don't meet a goal, let's say one of my goals is, patient will demo improve sleeping greater than 3 hours, because at the eval, they couldn't sleep longer than 2 hours. So at the day that I'm addressing that goal, they're still not sleeping more than 2 hours. Okay. So then at some point, I readdress that goal in addition to the goal of that treatment focus. But it's almost like chapters in a book. When I flip open to the table of contents, that's your plan of care. You see the chapters and you see the page numbers. When a reviewer looks at your plan of care and then looks at your treatment notes, it's just like chapters in a book. Okay, treatment, number 2 is goal number 1. Treatment number 5 is goal number 4. You just follow along in sync. You will never have a problem if you keep it very simple like that. But again, we complicate it and we're like, we're going to make up all these new goals and all these new ideas and we're going to bring all this new information in. Like, that's awesome for you, the therapist, because that keeps you excited and motivated and feeling good. That's awesome for the patient because it keeps them feeling good and motivated and everything. That's not what the payer is paying for. The payer is paying for very clear, concise, black and white. This is what I want you to do. Just do it. Don't complicate it. Don't give me extra stuff. Don't bring in more variables. This is what I'm paying you to do. And then again, we get mad because we're like, the payer is paying us too little for what we're doing. You're doing more than the payer is paying you for. The payer is not asking you to do those things, right? You are doing it as the clinician because it feels good to you and it feels good to your patient, but that's not what you're being paid for.
Okay.
And of course that goes into, and I've done it for years, how medically necessary is the manual therapy? Are we using it because it truly is medically necessary? Or are we using it because it improves compliance? How necessary is it? You know, we all know that you can't make a golf-based goal, but we know that a lot of patients are coming because they want to play golf better or they
Right.
want to play golf pain-free. Payers don't care about golf. They don't pay to have you golf.
Right.
So we hide the golf in the treatment. We don't document the golf because we know that that'll lead to problems, but we're using golf as a carrot on a stick. Are you really doing it ethically? You know, is that really, I kind of feel like we're blurring lines there that we shouldn't blur. If the patient wants to pay for golf, they can pay out of pocket for golf. I can do 20 minutes of therapy covered by the payer, and then we can do 30 minutes of golf performance covered by the patient,
Okay.
right? Totally reasonable. I don't know anybody who really does it that way, but that's what should be done. And so again, we feel like the third party payer undervalues our service, but the reality is we are the ones hiding and giving away our services for free because we want them to pay for it, but they don't pay for it.
I see.
We love it so much. We think everything should be covered, but you know, it's this total disconnect. So, um, any questions about that? Like, does that structure make sense for documentation?
Yeah.